Welcome back to your prescription for medication education, where I try to bring you quality information regarding medications and health related topics and try to make myself a better pharmacist at the same time. Today, I'll be continuing part two on my obesity topic. I hope you enjoyed today's video. Today's objectives are to review the energy homeostasis balance involved with food intake, define both traditional obesity classification and ABCD, and review pharmacological iatrogenic etiologies of obesity. Energy homeostasis is the balance of how much energy we consume and how much energy we expend. The brain, gut, and adipocytes are constantly communicating with each other to maintain this balance. This slide looks at how the stomach plays a role in maintaining this homeostasis. Gastric emptying refers to the rate at which gastric contents empty into the small intestines from the stomach. The stomach can detect how much volume is present via its neurosensory capacity. This includes many types of cells and tissues, such as interstitial cells of Cajal, fibroblast-like cells, smooth muscle layers, and the enteric nervous system. The vagus nerve detects gastric distension, which causes the release of neurotransmitters within the enteric nervous system and the vagus nerve. This process provides a negative feedback that affects feeding behavior by decreasing appetite and food intake. Rapid gastric emptying has been associated with obesity due to impaired satiety and increases in hunger and food consumption. There are multiple hormones that play a role in energy intake, satiety, and energy expenditure. In this slide, I will review some of the hormones and their function. When food enters the intestines, the release of various hormones occur that play a role on motility. Appetite-inducing hormones, also referred to as orexigenic hormones, include ghrelin. Satiety-inducing hormones, referred to as anorexigenic hormones, include peptide YY, glucagon-like peptide 1, oxyntomodulin, cholecystokinin, and amylin. GLP-1 is secreted by L-cell enteroendocrine cells in response to nutrients. It promotes insulin secretion and inhibits glucagon secretion. It also decreases the rate at which gastric emptying occurs by acting on afferent vagal nerves and myenteric neurons. This delayed gastric emptying promotes satiety. Amylin, which is co-secreted with insulin, enters the systemic circulation and directly acts on the CNS and the area postrema and the nucleus tractus solitari in the brainstem to inhibit gastric emptying, glucagon release, and induce satiety. Ghrelin activates the vagus nerve and stimulates food intake. Gastric inhibitory polypeptide, also referred to as glucose-dependent insulinotropic polypeptide, acts on adipocytes to influence adipose cell lipid cycling, which is a balance between lipogenesis and lipolysis. When GIP is combined with GLP-1 agonists, it attenuates its nauseating effect. Adipose tissue plays a major role in energy homeostasis as well. Leptin and adiponectin are the most impactful and understood adipose-derived hormones known as adipokines. Leptin is involved in satiety and energy expenditure by binding to receptors in the hypothalamus and the brainstem. Mutations that lead to decreased leptin synthesis, secretion, or activity can cause severe obesity. Adiponectin is involved in insulin sensitivity, lipid regulation, and fatty acid oxidation. Lower adiponectin plasma levels are associated with obesity, and when weight loss occurs through diet and exercise, adiponectin concentrations increase. The central nervous system responds to information received from the peripheral signals to maintain energy balance. The three main sources are the afferent autonomic pathway, mostly via the vagal afferents, the peripherally secreted hormones, which we covered in the last slide, and circulating nutrients like free fatty acids. The distension signals, along with gut-derived hormones like cholecystokinin, terminate at the nucleus tractus solitari in the brainstem, which then sends signals to the parabrachial nucleus, central amygdala, stria terminalis, and the medulla. These areas are involved in taste and satiety processing, emotional and motivational aspects of eating, and stress and reward-driven eating. Within the hypothalamus, the arcuate nucleus and the paraventricular nucleus collaborate to regulate energy balance. The arcuate nucleus contains neurons that stimulate appetite by releasing a glutamate-related peptide to stimulus such as fasting or ghrelin. The arcuate nucleus also contains neurons that release pro-opioid melanocortin to suppress appetite when activated by leptin. Both opposing neuron pathways converge at melanocortin 4 receptors in the paraventricular nucleus. Activation of melanocortin 4 receptors promotes satiety, and inhibition increases hunger. Obesity is defined by the World Health Organization as an abnormal or excessive fat accumulation that presents a risk to health. BMI calculated as weight in kilograms divided by the square of height in meters has traditionally been used to diagnose and stage obesity. Unfortunately, BMI has its limitations and does not measure adipose tissue distribution or function, and misclassifies highly muscular or frail individuals. Most U.S. guidelines, including the American College of Cardiology, American Heart Association, the Obesity Society, and the American Association of Clinical Endocrinology, define obesity as a BMI of greater than or equal to 30 kilograms per meter squared. The adiposity-based chronic disease, ABCD, is a diagnostic term adopted by the American Association of Clinical Endocrinologists and the American College of Endocrinology. ABCD is a progressive and chronic disease that is due to abnormal neuroendocrine regulation of energy balance and caloric intake, which leads to excess or dysfunctional adiposity. This in turn contributes to obesity-related complications and diseases that increases mortality or impairs quality of life. The diagnosis of ABCD involves both anthropometric and clinical components to determine the disease severity. The anthropometric components involve the use of BMI, waist to height ratio, waist circumference, and if needed, the use of dual energy X-ray absorptiometry when BMI and physical examination are inconclusive. The clinical component assesses for obesity-related complications, which include cardiometabolic, biomechanical, psychological, and social determinants of health. BMI is used to classify individuals into categories of obesity, with a traditional cutoff of a BMI of equal to or greater than 30. In Asia-Pacific regions, lower BMIs are recognized as the official cutoff due to greater health risk in these populations. For instance, India, South Korea, and Japan, the cutoff is 25, and in China, obesity represents a BMI value of 28. In South and Central America, for older adults, the cutoff of obesity is 27.2. In the US and Canada, the waist circumference cutoff values, which indicate an increased cardiometabolic risk for men, is greater than or equal to 102 centimeters or higher, and for women, it's 88 centimeters or higher. The weight to height ratio threshold is 0.5 or higher, which represents increased risk for both men and women for cardiovascular disease. Some evidence suggests that the waist to height ratio is a superior indicator of cardiovascular disease risk when compared to waist circumference. After the anthropometric assessment, a comprehensive evaluation for obesity-related complications and diseases is conducted. The AACE defines obesity-related complications as the clinical consequences that occur to organs because of the excessive body fat. Obesity-related diseases must meet 3 criteria. Number 1 being that they are more common in patients with obesity than the general population. Number 2, these are diseases that arise due to shared pathophysiological processes. In other words, obesity directly contributes to the disease via mechanisms it causes, like insulin resistance in type 2 diabetics. Criteria number 3, they also involve additional pathophysiological processes independent of obesity. Essentially, another mechanism must occur beyond obesity for the disease to manifest itself, for example, beta cell dysfunction in the development of type 2 diabetes. The differentiation between a complication or disease is not crucial because both require treatment. When patients with ABCD are evaluated, the medical provider should review the patient's medical history, perform a physical examination, request laboratory tests, and possibly imaging and diagnostic testing. The provider will assess for iatrogenic etiologies due to medications, non-pharmacological iatrogenic causes, and possible genetic related causes. The provider should also assess the patient for psychological disorders, internalized stigma, and discuss cultural beliefs and priorities. This table represents a very small fraction of the various complications and diseases that can arise from the provider's clinical evaluation. Complications like obstructive sleep apnea, prediabetes, and atherosclerotic cardiovascular disease can become blurred and overlap with type 2 diabetes, asthma, and atrial fibrillation. Part of the ABCD evaluation is to assess for pharmacological iatrogenic etiologies. Pharmacists play an important role in managing medications that contribute to obesity by identifying, preventing, and managing medication-induced weight gain. Let's review some of the classic medications known to increase weight or body fat. Insulin and insulin secretagogues like glargine and glipizide increase appetite, create an anabolic effect, increasing protein synthesis, resulting in lean body mass. For insulin, the weight gain is dose-dependent and is more pronounced in regimens using rapid-acting insulin compared to basal insulin alone. Beta blockers decrease energy expenditure by lowering basal metabolic rates and thermogenic responses to meals, and they also inhibit lipolysis by blocking adrenergic stimulation on adipocytes. Beta blockers can also promote fatigue, which can result in reduction in patient activity. Abdominal fat is more sensitive than peripheral fat to catecholamines, which can help explain why abdominal fat accumulation occurs. Vasodilating beta blockers such as nebivolol, labetalol, and carvedilol have less of a metabolic impact on lipid and glycemic parameters and should be considered for patients in need of beta blockers in which there is a concern for metabolic side effects. Amitriptyline and nortriptyline are well known to increase weight. This is due to strong antagonism of the H1 histamine receptor, which leads to increases in appetite and promotes sedation, leading to increased caloric intake and decreased energy expenditure. Paroxetine is well recognized for its long-term weight gain, primarily by antagonizing muscarinic and histamine receptors, which leads to increased appetite and sedation. Serotonin reuptake inhibition may also alter satiety signaling within the hypothalamus. Mirtazapine is also a potent antagonist of H1 histamine receptors, along with serotonin receptors. The weight gain due to lithium is multifactorial. It can induce hypothyroidism, decrease a person's metabolic rate, it can stimulate appetite via the hypothalamus, it affects glucose uptake, which can promote fat storage, and it also alters adipokines, contributing to metabolic syndrome and weight gain. Weight gain can vary between individual antipsychotics, but olanzapine and clozapine stand out. The blocking of H1 receptors along with serotonin blockade contribute to the cause of weight gain. Women, normal body weight at baseline, and drug-naive patients have a higher likelihood of being affected by the weight gain promoting effects of antipsychotics. Atypical antipsychotics also promote lipogenesis, increases lipid accumulation, and contribute to insulin resistance. TZDs cause fluid retention, promote lipid storage, and adipogenesis. Some antiepileptics are associated with weight gain, especially valproate and carbamazepine. Valproate increases appetite via the hypothalamus. Women, post-pubertal adolescents, and overweight patients are more susceptible, and valproate's weight gain is independent of dose and serum levels. Valproate also increases insulin resistance and alters adipokine levels such as leptin and adiponectin. Pregabalin increases weight via appetite stimulation, but gabapentin's mechanism for weight gain isn't fully understood. Patients receiving antiretroviral therapy often experience increases in abdominal fat gain, but this isn't caused by one particular medication or class and is related to metabolic changes from the treatment and the disease itself. Glucocorticoids increase appetite and dietary preference for high-fat foods through changes in the hypothalamus. They increase abdominal fat, which leads to insulin resistance. They also increase lipid synthesis and fat storage when used chronically. Finally, medroxyprogesterone causes increases in fat mass, especially abdominal fat, and can increase appetite. Once the medical provider has completed the anthropometric and clinical component in the diagnosis of ABCD, they will then determine the stage based on severity of obesity-related complications and diseases, which will guide the intensity of the therapy. In stage 1, a person has no obesity-related complications or diseases. The stage is considered preclinical obesity. Individuals in this stage are at risk of developing ORCD and should be considered for treatment interventions. The purpose is to prevent further weight gain and development of obesity-related complications and diseases. Individuals diagnosed with stage 2 have at least one mild to moderate ORCD. Individuals assigned to stage 3 have one or more severe obesity-related complications and diseases. In stages 2 and 3, treatment is aimed at relieving or even reversing obesity-related complications and diseases. The differentiation between stage 2 and stage 3 will be based on the provider's clinical judgment, which is based off the physical exam, lab tests, symptomatology, and other diagnostic procedures. And that was your dose for medication education. I do hope you enjoyed part 2 of my obesity topic. If you did, please consider subscribing, liking, and even sharing my channel. It would mean a great deal to me. As always, references are to follow. Thank you, and have a great day.